If you're watching this video, you are probably interested in what the day in the life of an internal medicine resident is like, and I'm here to break that down for you. Now, most people get their residency knowledge from shows like Grey's Anatomy, and don't get me wrong, I love this show. I think it's really good. However, Grey's Anatomy really depicts the lifestyle of a surgeon in residency. So if you're not into surgery and you're looking to different other specialties, Grey's Anatomy might not really accurately depict what the lifestyle of a resident is. But there's other shows that do tell you more about it, but at least I can give you some personal first-hand experience. So obviously I don't speak for every single residency program because there's just way too many, but what I can say is how residency is done at my institution, the institutions that I've been at as a medical student, doing rotations, as well as other friends that I have that are also in an internal medicine residency. So first off, I guess I would start by the day. So typically internal medicine residents, they work usually on like wards, so like on the regular floors, pretty much their day to day. It's usually 6 days a week, okay? And sometimes you might be on this 6 days a week rotation for an entire month straight. Usually not, typically it's not like, anything more than a month, but essentially you'll come in 6 days a week and you'll have 1 day off. Then the next week you do the same thing, 6 days on, 1 day off, 6 days on, 1 day off, 6 days on, 1 day off, and then you might switch to another rotation or maybe a clinic week where you might have to work only 5 days and then 2 days off. You'll do that for like a week or maybe 2 weeks, and then you'll go right back to the general floors team, which is 6 days on, 1 day off for a week, and you do that consecutively for another 4 to 5 weeks, and then you switch off. So that's the typical day schedule. Now, what kind of hours do internal medicine physicians in residency work? They work typically, I would say, anywhere from 8 to 12 hours a day. And obviously this is just 8 to 12 hours like they're in the hospital required. I'm not accounting for the time they need to get to work in the morning, the time they get to leave, and the preparation they do before or after their shifts. So sometimes a 12-hour shift can actually take you about 13 hours to complete. Sometimes a 12-hour shift, you actually finish it in like 12 and a half hours. So it all really depends. Typically it's 7 to 7. So you're supposed to come in at 7 a.m. in the morning, and then you leave at 7 p.m. The reason why I say 8 to 12-hour shifts though, is because sometimes you'll realize that you don't need the entire team to be there. Typically internal medicine residents, they're on a team. So the teams will usually have one senior. So this is usually like a PGY2, aka a resident in their second year, or a PGY3, a resident in their third year. They will be like the team leaders, and then you'll have some interns. An intern is considered a PGY1, aka a first year resident. And so most teams make up of one resident and 2 interns. Sometimes you might be lucky and you'll have 1 resident and 3 interns, but typically standard across the board, teams are 1 resident, 2 interns. And then of course you can have medical students or PA students as well. And so what usually happens is you come in the morning at 7 a.m. 7 a.m. is what you get, what we call sign out, right? So sign out is when you come into the team room, you speak to the night residents, the residents that stayed in the hospital overnight when you left the night before, and they're gonna pretty much run down your list of patients. And so say you have 20 patients on your list. They're going to go through each patient and say, this patient, nothing happened. This patient, nothing happened. This patient, we got called about him vomiting, so we started this medication. Next patient, next patient. And they're pretty much giving you a sign out of what happened overnight with your patients. Sometimes you might be blessed and have nothing overnight. Sometimes you might not be so lucky and had everything happen overnight. And so your job when you're coming in after sign out is to make sure that you handle whatever you got written on sign out. So if something crazy was happening, patient was having chest pain, blah, 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 your job is to follow up on that chest pain in the morning when you start your shift. Typically sign out, ideally can last anywhere from like 30 to 45 minutes for the entire teams, for all the teams. Your team specifically might only take 5 minutes or 10 minutes maybe. It all depends on what happened overnight. So once you get sign out, right? And typically the interns are the ones who are getting the sign out. The resident might just be listening, overhearing, but typically the interns get direct sign out overnight. And so once you get sign out from the overnight team, now you get to start your work. Typically you're expected to go to your desk, go to your workstation and start reviewing everything. You want to review the patient, any patient notes, maybe that the nurses wrote, maybe the overnight team wrote, maybe the PT or the OT, social work, etc. Whoever wrote a note on your patient, you want to review all those to make sure you're not missing anything. then you want to go over and check over the labs. You want to check over the labs to make sure that there's no abnormal values there. If there's any abnormal values, your job is to really address those values, right? And then of course, you want to follow up on anything that happened overnight. So once you review the entire patient's charts in the morning, you do that for all your patients. Remember how I said there's one resident and 2 interns. If say there's 20 patients on the team, each intern will have 10 patients, and then the resident will oversee all 20 of those patients. So as an intern, your job is to go look at your 10 patients, and the other intern will look at their 10 patients. As a resident, AKA the PGY2 or PGY3, you will review all 20 patients. Once you're done reviewing your patients, now you want to go see the patient. Okay, you're gonna go quickly do your evaluation. Hey, good morning, Ms. Smith, how you doing? Okay, how are you feeling this morning? Blah, 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 blah. Yesterday we talked about this. Are you feeling any better? This is what we did. This is what happened. But you have that small conversation. Now, you're supposed to do all this, like talk about all your patients, talk with them, etc. Ideally, in a perfect world, you'd have like 15, 20 minutes to do so. In the morning, as an internal medicine physician in residency, you won't have that type of time. You might only have about 5 minutes to really discuss with the patient, and that's okay. Obviously, some patients might only take 2, 3 minutes if there's no updates, and then some patients might take more, 10, 15 minutes. It all depends. But ideally, you want to be able to see all your patients in the morning. Once you see your patients, the intern sees their 10, the other intern sees their 10, the resident sees all 20 patients. You can now come back to the teamwork room and prepare yourself for rounds, okay? Rounds is when you meet up with the attending, so the main doctor in charge, and it's gonna be the attending, the resident, the 2 interns, and the medical students, and the PA students, and you guys are gonna go around the hospital to all the patients, one by one, and discuss the plan, like what we're gonna do moving forward. That's what we call presenting on rounds. So when you finish seeing all your patients individually, you're gonna go back to the team room and try to prepare yourself for rounds. Meaning, and how rounds typically is, it's like basically saying, okay, I'm the attending, I come in. Who's first on our list? Mr. Smith is first on the list. Okay, intern, present. Interns usually present, the residents kind of just oversee and chime in wherever the interns missed anything. And so the intern will say, this is Mr. Smith. He comes in with a history of blah, blah, blah. He presented to the hospital for blah, blah, blah. He was admitted for blah, blah, blah. This is what happened overnight. This is how he's doing currently on physical exam. I found this. His lab showed this. This is my assessment and plan for his COPD. He's currently still on oxygen. He's feeling better. We have him on inhalers scheduled. We have him on this, we have him on that. We're gonna continue the antibiotic treatment, and this is what we're gonna do. Boom. There you go to the next problem. For his high blood pressure, right now his blood pressures were okay. I did receive overnight that his blood pressures were really elevated, and so he get this medication. I think moving forward, we should start him on this medication and continue him to see how he does. You're pretty much going through the entire plan for that patient. After you guys discuss the entire patient with the attending on a team, with the whole entire team on rounds, that's when you guys will move on to the next patient. You go one by one till you see all the patients on your list. Then once you're done seeing all the patients on your list, it's usually around noon, I would say, sometimes even later than noon, unfortunately. But once you're done rounding with the attending, now you can go back to your team room and you can go ahead and start putting in work. Hopefully you could take a lunch. I'm not gonna lie, sometimes you don't get to take lunch. You have to kind of sneak food where you can, but it's fine. But essentially, once you're finished rounding with the attending, you'll go back to the workroom and then you'll start putting into action whatever you discussed on rounds. So if we said we discussed this patient on rounds and we deemed that this patient needs a chest x-ray, your job will then be to order the chest x-ray when you get back to the team room, and then you write in your note, why we're ordering the chest x-ray, what we're looking for, what we're gonna do if this chest x-ray shows up, blah, 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 whatever. If we said, okay, we want to order, oxycodone for this patient's pain, when you go back to your team room, you're going to order the medication. So when you come back to the team room after rounds, your job is to implement the plan you discussed with the attending. And that's what you're going to do in your notes, and you're going to put those in your orders. So after rounds, it's typically for you to start your note, but more importantly, place orders. Sometimes they might say this patient has a heart condition. We want to consult the cardiology team. After rounds is when you consult the cardiology team. You're going to consult the cardiology team, like, hey, I have a new consult for you guys. Okay, what's the patient's name and MRN, blah, blah, blah. This is Ms. Smith. She came in for this, blah, blah, blah. She had this heart thing we noticed, and we wanted to consult you guys for further guidance on management on this patient. And so you call the consults in the afternoon so that they can go see the patient as well. And then while the patient, you don't have to wait for them. They're gonna go see the patient when they got the time to do so. You're still writing your notes, you're putting in the orders, you're calling the consults, you're calling family. And some patients that are unstable, you actually have to go back and see them again to check up on them to see how they're doing, or if anything improved, or if things got worse, etc. And so that's pretty much what your afternoon is looking like. And same thing, if you're the intern, you're focusing on your 10 patients. The other intern, you focus on your other 10 patients. And if you're the resident, the PGY 2 or 3, you are overseeing the 2 interns and making sure that anything that needs to be done or is getting done, if they need assistance, you are assisting them. And the stuff that they can't necessarily do on their own, you are the one who's doing it, okay? And that's typically what happens in internal medicine. So usually I would say around from like 12/1 o'clock to about 3 p.m., 4 p.m., you're kind of just doing that busy work. And I'm telling you now, the bulk of the work you do in the hospital that really drags, honestly, especially in internal medicine, is the notes. Literally, like I can probably see patients, write orders, come up with plans fairly quickly. But what will take up, I would say, 70% of my time, 80% of my time is the documentation. If you didn't document it, it didn't happen. And if you didn't document it, you can't bill for it. And so when it comes to hospitals, they're very big on documentation, very big on billing. So it takes so much time to do all those things. And so, and also while you're ordering these medications, these imaging, calling these consults, speaking with family, sometimes talking to the nurses, the social work, et cetera, you still have to follow up on all these things you're doing. And like I said, that is what takes up a lot of the time. On top of that, while you're doing these things, consultants might call you back and say, hey, this is urgent. We need to take him to the operating room for blah, blah, blah. So you need to follow up and be able to field those calls. You're also going to be getting calls from the nursing staff saying, hey, the patient is complaining of this. Can you do something here? Patient is having chest pain. Can you come to bedside? So you're literally supposed to be doing all your work, but you have to be running up and down the hospital doing all these things. And you're doing that typically till about 3 or 4. It all depends on your institution. Now, if you can finish all of your work by that time, right, by 3 o'clock, 4 o'clock, whenever it's time to sign out, you can actually go home at a pretty decent time. Sometimes you can leave around 3 o'clock, sometimes you can leave around 4 o'clock. Now, remember I said sometimes you work 8 to 12 hours? It really all depends on what shift you're on. So a lot of hospitals have adopted this short and long system, meaning if there's 3 people on a team, right, one PGY2 or PGY3 resident and one intern, PGY1, or 2 interns, PGY1, there's 3 people on the team. Not all 3 of you guys need to be in the hospital for that team. And that's where the short and long system has been adopted. So what happens is you'll typically choose one person. You don't even choose, it's on a rotating schedule. But typically one person on the team is designated to stay long call, meaning while others can do 7 to 4, if they're done with their work, they can sign out at 4 o'clock and go home. Somebody has to be there from 7 a.m. to 7 p.m. to cover the remaining 3 or 4 hours for that team. That is one way they do it. So some people like it because typically it's like, okay, if I'm on long call today, 7 to 7, tomorrow if I finish my work on time and everything is like stable in the hospital, I can leave at 3 or 4 p.m. And then I can do that for like 2 days in a row. And then every 3rd day I'm long call. What other hospitals do is they rotate short and long call based off the team. So say there's 6 teams in the hospital, not all 6 teams need to stay long. What ends up happening is 5 teams will be short from like 7 to 4, and then 1 team will stay long and cover the entire 6 teams from that period between 3 p.m. and 7 p.m. and 4 p.m. and 7 p.m., whichever one it is. And when I say cover, it all goes back to sign out. So say I'm the short person today, right? I'm short, I get to leave at like, let's say 3 p.m. I finished all my work, I did everything by 3 p.m. Now my job is to make a list of all the important things that's happened today, the things that I want the cross-covering team to be aware of, to keep in mind, and then the to-dos, the things I want them to do between 3 p.m. and 7 p.m. that I'm not going to be in the hospital. I'm going to make this list, and then I'm going to go to whoever's long call, whether it's the team that's long call or the person that's long call, and I'm going to say, hey, I'm ready to sign out. And so the long call person, their job is to listen to me sign out. I'll like, all right, so the first patient on our list, this is so-and-so. He came in for this. If he feels short of breath, we want you to do this. This patient, he came in for this. If he has chest pain, give him this. This patient comes here. If he complains of this, give him this. I'm pretty much signing out my patients, telling you that it's really a brief thing, really. I'm really saying if any of these things happen, because this is what I can anticipate, it's called anticipatory guidance. This is what I anticipate. If any of these things happen, I want you to do these things. Now, here's some to-dos. At 6 p.m., I want you to follow up on his blood, on this blood draw. Make sure that the blood was drawn and this result has resulted. And let's say we're looking at a hemoglobin. This is a patient. I'll say, hey, this is a guy that's bleeding, and so we order the CBC to check his hemoglobin count. And if his hemoglobin is less than 7, I want you to transfuse 1 unit of blood. And so I'm pretty much giving him instructions on what I expect to happen and what I want him to do. Obviously, if I have 20 patients on my list, I'm not going to give him sign out on all 20 patients, but I'll maybe do about like 4 or 5, maybe even 8, 5 to 8 patients, I would say, the ones that I'm worried about the most. Obviously, he might get a call from the nurse about another patient that I didn't write on my list, but it could be something simple, but it's not something I anticipated, so I didn't write it down on sign out. And so essentially, I'm signing out to him. And so, like I said, if you are on a team or in an institution in which there's three residents there, and only one has to be long call, the 2 residents will sign out their patient to the long call person. Or if it's one team, and if it's one team that's designated long call and the other teams can be short call, all 5 teams that are short call will go sign out to the one team that is long call. And then for 3 p.m. to 7 p.m., that team is responsible for covering, fielding any calls that happen in between 3 p.m. and 7 p.m. while the other teams are off. That's what we call cross-covering. I'm cross-covering the other teams in the hospital, right? And so that happens until 7 p.m. Once 7 p.m. hits, now the day team can go home, assuming everything was handled and there's nothing still active happening. Now, when 7 p.m. hits, you can't just leave the hospital. You now need to do sign out to the night team. And so sign out can be a little bit more trickier at this point because most people are used to signing out their own team because you know those patients. But now if I'm long call, I'm going to sign out to the night team. So when a night resident comes in at 7 p.m., I'm going to say, hey, this is my team. This is what's going on. We want you to watch out for these patients. We want you to do these things for these patients. Here you go. Now, team number 1, they told me that this is their anticipated guidance. This is the guide, blah, blah, blah. This is what they want you to do. Cool. Now, team number 2, they said this, they want you to do this here. Team number 3, and I'm going to go down all the teams that sign out to me. I'm signing it out now to the night resident. So the point is, from 3 p.m. to 7 p.m. or 4 p.m. to 7 p.m., depending on your institution, you will be cross-covering. You will be covering the other teams that left early. And then from that time period, and usually people might be scared because you might be handling like 80 different patients, but typically you're not getting a call on every 80 patient, all those 80 patients. And the calls you do get, it's not saying, hey, what do you want to do about this patient's plan? What do you want to do about it? No, you're not here to make decisions. You're here to stabilize patients. So if they need like last minute orders, or they just need something simple, like, hey, patient can't fall asleep. Do you want to know if they get melatonin? Patient has a headache, can you give them Tylenol? It's usually like simple stuff. You're not making any life decisions during this cross cover period. At least you shouldn't be. If it's ever something really serious, your job is to call the team that signed out and be like, hey, I know you left the hospital, but this is what the nurse is calling about. What would you like me to do? Or is this something that you need to talk to your attending about? Okay. And then you pass it off. So that's pretty much what you're doing during cross cover, right? So it's usually not that bad. You just might get a bunch of calls that are like really simple, like, hey, family's here, they want to speak to you bedside. And then you can say, hey, I'm just cross covering right now. I'm not the primary team. I don't really know this patient that well. If the family wants to speak to someone, they'd have to wait till tomorrow when the primary team comes back in, okay? But the point is, after you're done cross covering, you then sign out to the night team, and that's when you can actually leave. All right, so I kind of make this video, I'm sorry if this video is pretty long, but that's pretty much a typical day of an internal medicine resident, internal medicine physician in residency. Okay, you're pretty much coming in from 7, and sometimes you can stay all the way till 7 p.m. as well. Sometimes later if something happens. But essentially, you're doing that, like I said, 6 days a week with 1 day off, and you're typically doing that anywhere from like 2 to 4 weeks at a time. And so it can be really draining, unfortunately, because it's a lot of patients to handle, a lot of cross-covering to do, management decisions, documentation, notes. I'm telling you, notes take up the longest. But if this is something that you're interested in and you feel like you can do it, then obviously do it, And the best thing about it, I would say, is that the more you do it, the easier it gets. So you really, really don't have to worry about that. Anyways, I hope this video was helpful for someone who's considering internal medicine. Obviously, every institution is different. Some institutions have it easier than this. Some have it harder. I think what I kind of explained to you was on the harder end of the situation. Some residencies, the team maximum is only 14 patients, so each intern only carries 7. Some institutions, the max is 10 though, so that's why I gave 10 an example. The most patients that, per the guidelines of residency all over the country, the most any team can have is 20 patients. So the most an intern can carry is 10 patients each. But a lot of institutions don't even let interns carry that many patients anyways. So typically, I guess, how many hours would you say you work a week? So if you do 6 hours, 6 days a week, 12-hour shifts, do quick math, what's 12 times 5, 60, technically 72-hour weeks, assuming you get in right on time and you get out right on time. It's about 72-hour weeks. But then when you start having those short days, it actually comes out to be a lot less. So with those short days, take those into consideration. Let's say you leave at 4 p.m. instead of 7 p.m. on your short days, and you're doing that maybe like 4 times a week. I would probably say, well, maybe let's say they do it 3 times a week. So let's say it's like 9 hours shorter each week. So maybe you might only work like 61 or 62 hours a week. Okay. So still above your average 40, but it's a lot better compared to those surgical residencies that you saw in Grey's Anatomy. And I think even surgery might even be a little bit better now. I'm not too sure. But yeah, that's the day in life of an internal medicine resident. And I hope this video was helpful. Please drop any comments, questions, concerns down below, and see you guys next time in the next video.